Good day everyone. We are Group 7A. This is our Pharmacotherapy Clerkship case presentation on pediatrics. Patient YTR is a 6-month-old Malay male infant. He weighs 9.1 kg and is 64 cm long. His head circumference is 42 cm. For chief complaint, patient's mother noted jerky movements on both arms and legs while breastfeeding, with uprolling of eyeballs, twitching of the head, bluish coloration on the mouth, and clenching of jaw. These symptoms aborted spontaneously and patient had postictal drowsiness. History of presenting illness include fever, cough, coryza, loose stool, less active and less sleeping duration. Siblings and mother noted of having URTI symptoms. Patient had no family history of epilepsy, aside from maternal aunt having febrile fit as an infant. Parents admit to practice smoking and consume caffeine. Birth history include spontaneous vaginal delivery at 38 weeks, birth weight of 3.2 kg, had prolonged neonatal jaundice. Mother had gestational diabetes mellitus and was on metformin during pregnancy. Patient was immunized up to 2 months old only. He had received BCG, 2 dose hepatitis and 1 dose diphtheria, tetanus, pertussis, polio, Haemophilus influenza type B vaccine. Patient had defaulted immunization due to parent refusal of having their child to get unnecessary side effect of vaccine. Patient overall developmental was up to age. Other information includes patient had 4 older siblings, which parents claim had completed immunization. Patient had been cared by grandparents. His diet history consists of exclusive breastfeeding for 3 months and started solids food at 6 months. The diagnosis of this patient includes simple and complex febrile seizure. Patient presented with fever upon admission. Previously, patient already had fever 3 days before admission. His parents also complained symptoms of jerky movement of bilateral upper and lower limbs, twitching of the head, and loss of consciousness. Risk factors for febrile seizures in this patient include family history and young age. The next diagnosis is generalized tonic-clonic seizure. Patient manifested a sign of muscle stiffness where he clenched his gums and showed jerky movement at both limbs. Patient was also diagnosed with status epilepticus. Patient was slightly feverish and had unresolved seizure despite receiving benzodiazepine. Patient was presumed meningitis with no specific symptom. Fever 3 days prior to admission, unresolved fever, several episodes of seizure, and lethargy. Other symptoms include jerky movement of bilateral upper and lower limbs, bluish coloration on the mouth, altered sleep pattern, loose stool. Lack of immunization control and young age may anticipate this condition. Next diagnosis is diarrhea. Patient was passing loose stool for 5 times on the second day of admission. The symptoms will present until day 7, but in smaller amount and at a lower frequency. Young age is one of the risk factors posed by this patient. Other than that, the use of antibiotics, such as benzylpenicillin and cefotaxime, is highly associated with diarrhea. Moving on to treatment, the first condition is febrile seizure. According to Pitt's protocol, patients should be given antipyretic in order to control the fever. The protocol recommended syrup or rectal paracetamol, 15 mg per kilogram 6 hourly. If the seizure present and lasted longer than 5 minutes, the protocol recommended rectal diazepam, 1.5 mg per kilogram. In this patient, he was given suppository paracetamol, 125 mg, which were appropriate. However, he was given a total of 6 doses of paracetamol a day, which exceeds the maximum daily limit stated in BNF children. The dose of suppository diazepam given was appropriate. Next is status epilepticus management. According to Pitt's protocol, if a seizure lasted between 5 to 30 minutes, patient should be given IV diazepam 0.2 mg per kilogram in slow bolus, and if the seizure continues for more than 5 minutes after that, patient should be given IV phenytoin 20 mg per kilogram. First, patient was given IV phenytoin and IV diazepam together, even though phenytoin should be given if patient still have seizure after 5 minutes of diazepam dose. Secondly, the dose of diazepam and phenytoin were incorrect given to this patient. The dose of IV diazepam should be 1.8 mg, while the dose of phenytoin should be 180 mg. For the treatment of meningitis, according to PITS protocol, patients should be given IV dexamethasone 0.15 mg per kilogram, maximum 10 mg q6 hour for 4 days before or with first dose of antibiotic. According to National Antibiotic Guideline 2019, the empirical meningitis treatment for children more than 3 months are IV cefotaxime 200 to 300 mg per kilogram per day in 4 divided dose plus IV benzyl penicillin 100 mg per kilogram per day in 4 to 6 divided dose. According to NAG, the regimen for herpes simplex encephalitis is IV acyclovir 10 to 15 mg per kilogram per dose Q8 hour. The dose for both IV benzyl penicillin and cefotaxime was appropriate. The rationale for giving IV acyclovir is to cover for herpes simplex meningitis, since caregiver refused lumbar puncture for CSF culture and sensitivity tests. However, the dose of acyclovir given was higher than the recommended dose. IV acyclovir 91 mg Q8 hour is appropriate for the patient. Patients should also be given IV dexamethasone 1.4 mg to reduce inflammation caused by meningitis. Next part is drug-related problem. Drug-related problems in this case include patient missed immunization dose since 2 months old due to parent refusal. Incomplete or delaying immunization is associated with many disease conditions. Hence, parents should be educated on the importance of vaccination in children and how to complete the remaining vaccine doses for children who have delayed the immunization. Next, there is absence of corticosteroid therapy for this patient. Since corticosteroid therapy is proven to be beneficial for meningitis, IV dexamethasone 0.15 mg per kilogram Q6 hour for 4 days should be considered for this patient. Symptoms of recurrent fever, i.e. temperature rise, should be monitored. Moreover, benzyl penicillin may increase risk of seizure, especially in patients with history of seizure disorder. Signs and symptoms of seizure should be monitored such as jerky movement or changes in behavior with use of benzyl penicillin in this patient. Next, DRP is potential adverse effect of benzyl penicillin, cefotaxime and diazepam, which is diarrhea. Patient was passing loose stool for 6 consecutive days after initiation of antibiotic therapy and diazepam. Antibiotic-associated diarrhea is common among patients taking penicillin and cephalosporin. It develops after taking antibiotic, and it usually lasts for a few days. This type of diarrhea requires no specific treatment, but it is necessary to assess the degree of dehydration and to give symptomatic management for this patient. As such, giving ORS to improve hydration status. Besides, there is also potential adverse effect of benzyl penicillin that is manifested by this patient, which is hyperreflexia. The use of high dose of this drug may cause neurotoxicity, and this can be shown by symptoms such as hyperreflexia. As an intervention, we should monitor the occurrence and frequency of hyperreflexia or any other neurotoxic symptoms such as muscle twitching. Furthermore, patients started to develop extravasation at granular insertion site on day 6. This occurs because of the IV administration of drugs, which can cause local inflammation and irritation at the injection site. Thus, stop the injection if necessary and assess the affected area. Hot and cold dressing can be applied to reduce inflammation. Last is the potential diazepam and phenytoin interaction. Diazepam can increase the level of phenytoin in the blood. Thus, symptoms of phenytoin toxicity should be monitored. Moving on to monitoring plan. For effectiveness of the treatment, monitor the sign and symptom of infections, temperature, full blood count, and inflammatory markers. Besides, culture and sensitivity tests can be carried out to find out possible causative agent of the infection. Daily neurological assessment is required to assess patient cognitive function. In terms of safety, monitor signs of anaphylaxis during the first dose of antibiotic. Besides that, renal profile and fluid balance should be monitored. Monitor side effects of each medication indicated, such as diarrhea, inflammation, or extravasation at injection site and rash. Other relevant pharmacist interventions include: first, to educate the parents on the importance of immunization in children. We should ask the reason for not allowing the child to get immunization and explain on the consequences of not getting immunization. Second, to advise parents to monitor any signs of seizure attack and to educate them on the emergency treatment for seizure. Lastly, we should advise parents to monitor the development of child at home, i.e. vision, hearing, and also speech. That's all from us. Thank you.